lot of good information about all the different things that are going on, kind of where we want to be. I did have to look up all the names of the Jetson family so I could decide which one I wanted to be next year. So I've got that picked out. If anybody needs some help, I've got their names. So I'm going to turn it over to Walt Culbertson, and we're going to talk about health IT security.
All right, very good morning. My name is Walt Culbertson. It's a great thrill to be standing in front of a podium once again at Florida State University. Many thanks to AHCA for inviting me to moderate this very important session. Of course, that's what all moderators say. Evan and I were arguing whose panel is more important. But you don't have to do anything more than basically these days flip open your tablet or the newspaper or turn on the TV, and you're reading the joy and fun many organizations are having connecting up to the internet. And in fact, when you take a look at 2014 alone, there were 264 reported, underlined, keyword reported, people actually knew about it, breaches covering the personally identifiable information of 65 million Americans, basically 1/3 of us. 2015, as we know, has been and will be very sadly a banner year for the challenges of breaches in IT security. We're all aware of the recent fund that the Office of Personnel Management is having. 1 week it's 4 million people, the next week it's 18, now it may be 30. And then to start this year out in healthcare, we had a couple of big announcements. March 13th, Anthem announced that 78 million records were breached. Not to be outdone, but to help out a fellow blue and keep another name in the highlight, Primera announced on March 17th that 11 million records were breached. So I got to thinking about this title of the panel on the way over from my drive from Jacksonville, and the last time I stood in front of a podium at Florida State in '99 and 2000 when I was very honored to teach conducting business on the internet, or e-business, but at the time I was daydreaming about e-health, and here we are 15 years later. And as one of those people who got a Dear John or a Dear Screwed letter in the mail, because my information was one of those fun folks, I got to thinking what it's like to be a provider. And then I got to thinking about the title of this session, Health IT Security Savvy. Well, you know, if you're an average doc, it's really not about security savvy. So I want you to take out your brochure, strike out the title of this session, and write in 4 words: 50 Shades of Gray. Now, before you get excited, and Paul, you start loosening your tie, our panel will not be discussing, reenacting, or describing their favorite scene from either the movie or the book, but helping providers with the real world whips and chains. And that's basically what it's like, on one hand, to be nudged, pulled, and dragged into this e-health world, but yet at the other time, you've got the bad guys clearly staring at docs, and right out of a Clint Eastwood movie with the roles reversed between the bad guy and the good guy, looking at docs and asking them, go ahead, make my day. Or worse yet, do you feel lucky, doc? So working through this for us today and helping us with some great information is our wonderful panel. And starting with the fact that every discussion like this, you need legal counsel. Go figure. We're very thrilled to have with us one of the best, Tallahassee's very first Chief Ethics Officer since October 2014. Go figure, our state capital, with all this government, we finally get an ethics officer. Julie was also the Chief Counsel, Chief Privacy Officer, and Chief Ethics Officer for the Department of Health for a decade, which also made her a very good candidate to be the CJO. Or the
and also a lightning bolt comes down on
See?
these people.
Isn't that amazing how that happened?
It is, wow.
Please welcome to the panel Ms. Julie Meadows-Keith. Julie, because this is about technology, go figure, the word technology and health information technology, we're very pleased to have with us from one of the preeminent organizations helping providers in our industry work through health information technology, the Vice President of Strategic Relations, a guest lecturer at Boston University, and an adjunct professor at Pfeiffer University. Please welcome to Tallahassee and our panel, John Daniels. John.
You did.
Well, it's one thing to legalize it, it's another thing to make it, but at the end of the day, somebody's got to roll it. So here with the real world of what it's like to roll and have to implement security in an organization with over 20 years of experience at the Inspector General, a information security auditor certified since 1992, which means you probably started when you were 5. Please welcome Ms. Karen Calhoun, the Information Security Manager for the Agency for Healthcare Administration. Welcome, guys. Well, I promise you, Karen, you're kind of sort of going to be on the hot seat, so I'm going to lob this first one at you. We're reading in the paper that our own government, very large organizations with a lot of wherewithal and a lot of bucks to throw at security, have not done a great job. So if you're the average provider looking at all of this, being pushed to digitize and share information, what's the average provider to do given the realm of cyber attacks and where we are with cybersecurity these days?
Well, I'm sure that the average provider wouldn't want to hear what I've got to say about this, but the first thing I did was I went out there and researched the topics. And there's plenty of information out there for you to find, and actually those 2 big government organizations have already released some information on how they're handling their crisis. And I have 2 different sites if y'all are interested in me providing you with the links to those sites from OPM, who actually has a plan, and Department of Justice has also released a plan about how they're handling their crisis. So what would you do though, once you read that stuff, you go, well, what does this mean to me? And the first thing I would say to you is whether you're a small provider or a medium provider or a large provider, is you have to say, what are my risks? Where are my risks? And you really have to think about this, and you're like, well, I don't understand what risks are. Well, then read up on it a little bit or ask other people about it. Ask other groups that are similar to you, what are they doing? Because you have a finite number of dollars to implement controls to help you with anything in cybersecurity. So if you're a small provider, you would probably want to talk to some small providers because your resources are more limited than large providers. But you can implement controls wherever you think you have your risk at the amount of dollars that you have. But the number one risk that I see is your own employees. That's your number one risk. So what can you do? Well, I'm a retired auditor. You're never a former auditor. It stays with you forever. So what can you do with your employees? Well, you have to train them. Well, I don't have time to train them. Do you have time to deal with a breach? Do you have the dollars to deal with a breach? So and you don't even have to train in person. You can develop webinars. You can buy information for people to actually train your people. But you've got to train them on what to do. The second thing is on your devices. Most of y'all, I hear all about the devices. Do you have all your devices encrypted? Whether you're a small provider or a large provider, that's where the information is going missing, is on your phones, your laptops, whatever you have. Are those encrypted where if people lose them, can people get into it? Are they password protected? Are your phones just sitting around where anybody can pick them up and look at them? So those are some of the first things I would start with.
Julie, John, thoughts?
I'll go real fast because she's already said all of the ones that I think are key, and I would focus first on the encryption piece because I've always called that your get out of jail free card because if you have a laptop that's like owned by your company or your practice stolen and that's encrypted, you might be out that computer, but you'll know that the information on it is unreadable, unusable, and it can't be transferred. So there's actually a technical definition for what encryption is. It's not just that you have a password on it that you change every 30 to 60 days. It's actually a technical standard. So you first start with that. But real fundamental and this is what shocked me, because I came from Department of Health, and for a few years I went into private practice, actually assisting physicians with implementing HIPAA and high-tech requirements, meaningful use, adoption of electronic health records. And when I would talk to physicians in smaller practices, even medium practices, you ask them kind of basic questions, like, when's the last time you had HIPAA training? And they're saying like 19, which is like, and where's your policy? Well, it's in a dusty notebook in my office manager's office. Well, who's your privacy and security officer for HIPAA? Well, my wife. So, it's these very basic things that I find hadn't been done. And when you kind of prod a little bit and explore why, physicians are frustrated. Physicians are pressed for time. They have more demands on their time for documentation. They're less profitable than they've been in the past due to the new funding and payment models under our new healthcare schemes in the United States. So this is like real low on their list of priorities. But I would always talk to them about one case that came out of Arizona, I believe, and it was a small cardiac practice. I hope no one is sitting in the audience from that practice. Okay. But they were just like a medium-sized cardiac practice, and really good results for their patients, busy doing a lot of cardiac surgery, and probably saved a lot of people's lives. And they had a thing where they had an electronic appointment reminder modality on their website, for patient convenience. Well, for some reason, that part of the website appeared on the public internet. So if you got onto the cardiac care website, you could pull it up and see patient names and when they were scheduled. Okay, so that's kind of bad. Okay, well, but you can remedy that pretty fast. You can just pull that puppy off the internet. You can send a letter and apologize and say, gosh, I'm really sorry this happened. We will not sin again. But you must report that to Health and Human Services, okay? That's a required report to Health and Human Services every year. Gosh, he just doesn't like this. So what happens is, once you've notified HHS that you've had an issue, they don't just look at that little issue you had with your software or your website. They want to know a bunch of stuff. And when I worked at Department of Health, we had a few of these, and you get this really awesome letter from HHS that's probably about 6 pages long, both sides of the paper. Please provide the following information. When was the last time you trained on HIPAA? Please provide an attendance list for all your employees. Please provide a copy of the training. Please provide your updated policies and procedures, and all of these different things for the last 5 years. So they're not just worried about what happened for this particular incident, they're looking back at your organization for 5 years. So what happened to this practice, this small cardiac practice, they got fined over $100,000, which, if you're thinking about doctors, that might not seem like a lot, but it is. And then the thing that's most inconvenient is that you're under a settlement agreement with HHS, which means that you're being monitored by them. You're being kind of audited by them and looked at for a period of time, and you better sin no more. So when she references that, well, it's expensive, it's inconvenient, people don't want to do it, you better be doing it on the front end or you'll be doing it on the back end. That's my take on that.
Very good. Well, John, once upon a time we had the joys of BYOB, at least I did. Now we have BYOD. And if you did a BYOD and you ended up getting one of those nice letters, you're probably going to wish you had done a BYOB. But John, tell us, there's so much promise with mobile computing, mobile devices, and healthcare devices, but they come with, I think, unique risk and opportunity. So can you describe, from your perspective, what's an organization to do to start bringing in those devices and really have them safely and securely used?
Wow, so much to talk about, and in light of 50 Shades of Grey, for that matter. There's 50 Shades of Grey. I mean, there's so much at risk with using personal devices and connecting personal devices. That's why a lot of CIOs are a little averse to having physicians come in and connect their devices to the network, because what it does is it introduces a new risk to the hospital or the healthcare network. And speaking of risk, one of the questions that I ask when I teach the different courses that I teach about risk is, do you agree with this statement? A risk accepted by one is a risk shared by many. So when you think about that, when you're doing your risk assessments, and particularly around the BYOD issue, try to answer that question as you're looking at the issue. If I accept the physician bringing this, or nurse, or anybody else in the organization, bringing their iPad in and connecting it to my network, if I accept that risk, then not only am I accepting that risk, everybody else in the organization is accepting that risk, and my patients are accepting that risk, because the risk is the possibility of disclosing information that you're not supposed to be able to disclose. So that's probably the biggest risk. In terms of doing risk assessments, I know we were talking about risk assessments just a minute ago. As a provider, what is a risk assessment, or what is a risk? A risk is really what you get when you look at your threats and you look at your vulnerabilities, add those up together, and that tells you what your risk is. And once you identify what your risk level is, then the question you need to ask yourself is this the level of risk that my organization is willing to accept today? If it's not, then what level of risk are you willing to accept? And then what's that gap? And then once you figure that out, then you got to figure out, how do I mitigate all of those issues between what our risk is today and what I'm willing to accept, and how do we fix that? If BYOD is one of the risks that is in sort of that gap, then you've got to look at trying to figure out how to mitigate that risk. And there are many ways to mitigate that. One is maybe instead of allowing your staff to bring their own devices in, why don't you buy devices for them so that you can control the security configuration of those devices and make sure that they're operating within the parameters that you expect them to operate. At one extreme level, you can just completely disallow any connection of mobile devices to your network. But considering the direction healthcare is going today, we're very mobile people, and I don't know that that's probably the best solution. But I don't know what else to add other than you just got to figure out what level of risk you're willing to accept, and if you're willing to accept the risk of somebody attaching their personal devices to the network, then that's a decision you've got to make. But once you accept that risk, then not only are you accepting it for yourself, you're accepting it for everybody else, including your patients that you're treating.
Very good. And Karen, how is the agency handling bringing in your own device?
We don't allow it.
Pure and simple.
Yeah, our agency doesn't allow it, and but we have a lot of controls in place, even for the ones that we buy for our employees. But if you do allow people to bring in their own devices, you can have controls in place, and they can be, you can train the users, and then you also want to be able to wipe devices, whether they're your devices or if they are personal devices of the people that work for you. You should have the capability to wipe their devices if they leave your employment or if they lose their devices. So that's one control you can have in place if they are going to bring their own devices. And you also can have a policy where they have to abide by whatever software you use to control stuff. So you have a lot of power at your fingertips, but you're going to get pushback from people because everybody wants to use their own devices now because it's a lot easier. I have 2 devices, and people don't want to have 2 devices or 3 devices. So you're going to have to figure out what's best for your employees, but the number one thing is what's best for your organization. Because, again, what risk are you willing to take?
Very good, thank you. Julie, in the early days when you and I were out evangelizing that thing called HIPAA, we thought that we were basically talking about the Health Insurance Portability and Accountability Act, but we very quickly found out as we talked to physicians that they are all very fervent members of the other HIPAA, the Health Institute of Providers and Procrastinators and Avoiders. So all these years later, have we gotten any better? And do you think in light of the initial emphasis on HIPAA of covered entities, providers, healthcare clearinghouses, and health plans, does HIPAA need to change, or do you think that we can live within the framework of where we are?
Well, one thing I always talk about when I talk about kind of the evolution of HIPAA is that in 1996, when HIPAA came out, you were using those StarTech phones. Do you remember those? They were those kind of clunky phones and they flipped, you know? And the type of device that you had in 1996 is so much different than what we have now. And there is an argument that HIPAA's become kind of outmoded, and there was an attempt to modernize it with the HITECH Act, Health Information Technology for Economic and Clinical Health, because I hate undefined acronyms, but that was actually part of the economic stimulus package that infused money into the healthcare system to encourage folks to adopt electronic health records. So we didn't have as many electronic health records. We didn't have iPads. We didn't have all of this information sharing through health information exchange during that period of time. So there's been a lot of confusion even about whether HIPAA applies to things like health information exchanges or conduits of information where, you know, you're sending information from point A to point B, and the data may rest somewhere for a few minutes, an hour, a few seconds, and there might be some opportunity to lift that data from where it is for a short period of time. There's an ongoing discussion about whether that's covered under HIPAA or not. Likewise, you have this ability to amass great amounts of information about patients. You have this big data concept that we hear so much about. So, and then we have the meaningful use requirements kind of added into that about how we're supposed to be measuring our practices and our effectiveness in treating chronic conditions and what treatments work best for diabetes and high blood pressure and what physicians are most efficient at controlling chronic conditions. So you think about all the different ways our health information's being used now in 2015. You think of all the different ways that information's being conveyed that weren't present in 1996. You think about HIPAA and you go, well, I wonder if this still fits or if we need a new modality to actually regulate it. And then you kind of mix into it that you do have physicians that haven't even really embraced HIPAA. So you kind of have all of this together. And I will say that the big organizations, hospitals, large practices, seem to have embraced it more because it's an economic reality they have to embrace. But a physician in like a rural area or a small town may not have had that opportunity or the economic ability to comply. Right. So I think it's a complex question.
Yeah, well, and I think there are still very obviously a lot of procrastinators and avoiders out there, and some, by the way, who think they have done security right. I did an audit in 2001 for a small practice, helping them get with HIPAA in Madison, a small town. About 2 years ago, I stopped by there to see how things have changed, and the office manager, who was probably also the privacy officer and Probably good grounds for a divorce from her husband, the doctor, but she was very proud of the fact that she had gotten with it. So she said, look, no stickies. She used to keep stickies on her terminal with the password. I couldn't resist. I opened the drawer. There's the sticky. So trying to get with it. But you know, the other challenge we have, John, is that looking at MU3 and some of the push in that to be able to incorporate patient-generated data in a medical record. So how about HIPAA? And there are a lot of intermediaries that help patients collect, and use that data, refusing to sign BAAs or become part of that. So how do we deal with that?
Well, if you don't mind, I'd like to take this because I want to sort of answer that with a question to Julie and Karen. Since we're talking about HIPAA, we're talking about meaningful use, and you brought up the fact that, of course, we're collecting all of this data in electronic medical record systems, which was actually the reason why HIPAA came into play to begin with, is because we were moving towards this electronic medical record keeping system, and the government saw that, well, the industry isn't doing what it needs to do to protect the health and welfare of the population, so it took it upon itself to give us what we know and love today as HIPAA. Well, with meaningful use, there were some provisions of meaningful use that impacted the original HIPAA law from 1996. A couple of those have already been implemented. One is the one that we've, I think, talked about already today, which is the breach notification rule, so that if you disclose information and it's not encrypted, then there's certain rules you have to follow to notify the people that are affected. The other one is an expansion of the business of the definition of business associates. So more organizations are now sort of fall under that definition of business associate, which means that hospitals and healthcare providers have to go enter into a business associate agreement with those other entities that they may be doing business with. But the third one, which has not been implemented yet, and this is where I want to ask the question here, has to do with the notification of disclosures. So under the original HIPAA law, the requirement for disclosing information was sort of went like this, and you can help me because I'm certainly not the expert on this. You didn't have to account for disclosures of PHI, protected health information, if it had to do with treatment or payment or other healthcare operations. So as long as you were disclosing information within those three areas, you didn't have to account for those particular disclosures. But with the meaningful use law that was enacted, what was expected is that a new rule would come out modifying the HIPAA law, or basically expanding it to say that you would be required to account for any disclosure of PHI from an electronic medical record, regardless of whether or not it was for treatment, payment, or other healthcare operations. However, that law, or that rule, has not been written and has not been implemented yet. So to get to your question and to sort of talk about what you were mentioning just a minute ago, why not? I mean, it seems like to me that that would get a lot of folks' attention on protecting personal health, or protected health information, if they had to, with the implementation of EMRs, they had to account for every single disclosure that they made from their electronic medical record of PHI. So why haven't we moved towards implementing that particular rule? Do you know?
Well, I can just imagine, and I don't know for sure, but I can just imagine that there's a cost associated with enhancing existing EHRs to have that audit capacity where you'd be able to actually go back and pull at a certain period of time, like what record was accessed at what particular time. So I think there's probably maybe some technology that hasn't evolved to that point yet, or just that enhanced responsibility that you want to be able to, if you're especially in a treating relationship with a patient, you want to be able to convey that information to, say, another provider without having to jump through a lot of hoops. But I will say that in Florida, disclosures other than for treatment, you've always had to have authorization from the patient. to exchange health information for payment or operations. State law in Florida has always been stricter than HIPAA. We have our own state law requirements. So I always emphasize that too. Some people don't even know that in Florida we have stricter laws than HIPAA. So I don't know if that answers your question, but it does kind of further complicate the matter.
Yeah, and I don't argue that at all. But from a technology perspective, being a CIO, former CIO anyway, if you've implemented an EMR, then as far as I know, most EMRs have an auditing capability where you're able to go back and audit to see who's accessed what information or what have you. Is that technology good enough, you think, to help from an auditing perspective?
You're asking me? I would say, how many people have that capacity? How many people actually know if you have that tracking tool? Because a lot of people do not. They don't turn their logs on.
And are you looking at the logs?
Yeah, you have to. Are you reviewing them?
That's kind of the big thing. One report that I would cite to you all that you can pull off the internet. Verizon every year does a breach investigations report, and they've been doing it now for at least 5 years. And you can look at the most common breaches in what industries, and I'd say that if you're concerned about this issue at all, take a look at it. The things that most frequently impact healthcare organizations, the kind of breaches, is physical theft and loss. So we've already kind of talked about that with our devices. And this report, I'm just looking at a statistic here, it says 15% of incidents still take days to discover, and that you should be incentivizing your workforce to report all incidents within a certain number of hours. Now, you're correct that a lot of EHR products do give administrators the ability to see who's looked at what record when, especially within your own workforce. But the question is, who is looking at all of that information? And that may be a manpower and resource issue, that you may have this turned on, you may have it tracking, you may have this wonderful log, but if you don't have someone that's checking that on a consistent basis, then you can miss a lot, even if you've purchased the technology. Or if you're ignoring the alerts. A lot of these systems have alerts that beep or buzz or somehow interrupt your day, and people will, as a matter of course, turn them off. So,
Very good.
human error.